had an educational session regarding what would be the best first line of therapy for BRAF-mutated metastatic melanoma. And so we started out by first looking at biomarkers to see if there were any effective biomarkers available. And I think a lot of people get very caught up with what's the PD-L1 receptor status in melanoma patients in order to determine whether or not they should get immunotherapy. And what we did was we went through the data and presented data that showed that PD-L1 in melanoma is really not a good prognostic indicator as to whether patients will respond to PD-1 therapy. So the bottom line is that patients should be given the opportunity to get immunotherapy, no matter what their PD-L1 status is. However, if you have a patient who's got BRAF-mutated melanoma and they have very aggressive disease and they have brain metastases or their performance status is poor, you may not want to give them upfront immunotherapy. You may want to go ahead and give them BRAF inhibitors since you have that option in this patient population. After we discussed biomarkers, and then we also discussed what are some of the new and exciting research biomarkers that are being looked at. IL-6 and CRP are clearly two very easy to monitor serum markers that have been shown to be elevated in patients who have a poor response to immunotherapy. So that was actually just data presented here at this year's ASCO. So that'll be incorporated into future trials moving forward to determine if, in fact, these do help us decide who should get immunotherapy and who shouldn't. We then had a little bit of a back and forth between should patients who are BRAF mutated get sequential immunotherapy versus combination. So what does that mean? If you give patients sequential therapy, it means they either get immunotherapy first followed by BRAF inhibitors, or they get BRAF inhibitors first followed by immunotherapy. Versus give everything together, give immunotherapy and BRAF targets. The combination of immunotherapy and BRAF targets right now is being explored in clinical trials, and that's not an FDA-approved treatment regimen at this point. But what we've seen is that progression-free survival looks to be a little bit better in the combination. However, the toxicity of combining all these agents can be, can be really problematic. So we have to find a correct sequence. Do we need to give them all at the same time? Can we give BRAFs, then immunotherapy, then BRAFs? Should we give immunotherapy, BRAFs? And again, these are being explored in trials. We don't really know what the right sequence is. Or do we just give sequential therapy and just decide, well, even though the patient has a BRAF mutation, they have low volume of disease, their LDH is low, they don't have brain mets, they look good. Well, that's a patient who should probably be given immunotherapy right off the bat and see how they do. If they do well, great. If they don't, you can then transition them over to BRAF inhibitors. But if you have a patient who's not doing well and has a high volume of disease and is very symptomatic, you're going to want to use those BRAF targets up front and then upon progression, then go to immunotherapy. So the bottom line of the session was there's really not any right answer. I think clinical trials for all metastatic melanoma patients should still be the first right and only answer. But if patients either don't want to participate in a clinical trial or are just not eligible, then what we need to do is look at the biomarkers we have available, look at the patient, look at the data, and really make the best educated decision as to what the best therapy is.